couple of things we want to focus on is the workup. I'll introduce some of the imaging tests we have and touch base on how we could use them in the workup, estimating malignancy based on imaging, and some of the key features of tumors in the different compartments. It's important to identify which compartment the tumor or the process involves, and then just the principles of the imaging workup. So in the radiology, we have a lot of imaging modalities. In spine imaging, we use all of these. Ultrasound really we use for only babies, of course, but other ones are used a lot. Just give you a quick overview of the different modalities. First of all, the radiographs. Of course, the image contrast here depends on the, we use X-rays and it's based on the electron density of the object we hit and its constituents. And while this is the most basic, the oldest, cheapest study, it's probably the hardest to interpret because we basically reduce 3D objects into one dimension. And we're primarily looking at the bony structures when we talk about X-rays. And we need at least approximately 1 centimeter mass to see it on a plain X-ray, and approximately 50% loss on bone mineral density to reliably see it. So we'll miss a lot of lesions on plain X-rays. We'll estimate up to 40% of lesions will be missed. Some of the other things important with X-rays, if we see more than 50% of the cortex destroyed by the tumor, there's a higher risk for pathologic fracture, something to look for. Epidural lesions may be hard to see on plain X-ray, but we look at things like osseous erosions along the posterior margin of the vertebral body. That one space we can see because there's bone next door to see. And of course, we have different types of lesions. We have lytic lesions, we have mixed lesions, we have sclerotic lesions. They all look different. So nuclear medicine bone scan, we use technetium-99 labeled MDP or white, so it's really a physiologic test and primarily used for disease extent. And we get 1 and 2D images. It's also an alternative to MRI or CT if patients have pacemakers or hardware. And here the tracer accumulates in the new bone that's formed in response to the lesions. It's not really the lesion itself, but it's the response that we see. Even as low as 5 to 15% alteration in bone turnover is enough for us to see. And the amount of accumulation is sensitive to blood flow. The reason this works is most metastases, for example, are hot, so to speak. So we see these on a bone scan. However, some are cold because there is no reactive bone formation or blood flow is poor. Some of the examples of these type of lesions are myeloma, thyroid mets, maybe called them bone scans. So these should be evaluated really with the bone skeletal survey. Most common false negatives we get with nuclear medicine is with multiple myeloma, up to 1/4 of the cases, with leukemia, anaplastic cancers as well. We can see lesions that are as small as 2 millimeters, so see small lesions. With prostate cancer, because of its very high affinity to bone, we may see something called a super scan where everything lights up. So you think it looks like a very beautiful study, all the bones are nicely outlined, but it's really a case of a super scan because there's mets everywhere. And there's mimics of tumor that we have to be aware of that in nuclear medicine bone scan we see. Trauma, infection, arthropathy, or even disused osteopenia. These can be hot on the bone scan, so to be careful. In general, if there is a solitary focus in the spine, even in patients with cancer, only about 50% of the time it's actually a met. So it's something to keep in mind. PET is also a type of nuclear medicine study where we use glucose metabolism because of neoplastic cells have increased glucose metabolism. We'll see them. This is, of course, a more sensitive and specific than a bone scan, but also more expensive. And we have sensitivity and specificity up to 98, very high, where bone scan is sensitivity is approximately 80%, and specificity is similar. PET is more sensitive for lytic than sclerotic mets. Lytic lesions in general have higher glycolytic rate and relative hypoxic environment, so that's why this works that way. While sclerotic lesions tend to be more less cellular, less aggressive, and not as likely have this hypoxic component. This can be also used for treatment follow-up. As the standard uptake values decrease, it's an independent predictor for duration of response. This is one modality that can also help differentiate between malignant and osteoporotic, for example, compression fractures. CT, of course, technically works similar to radiographs. It's just a stack of radiographs in a sense. We get 2D images, some cases 3D images. This is really the best study for bony elements, cortical destruction, preoperative planning. In general, compared to an X-ray, we would see a bony met on a CT likely as much as 6 months earlier. MRI, of course, still a more sensitive study in the high 90s versus mid to upper 60s for a CT. Specificities are similar. CT has some artifacts, suffers from. Now, if patient has osteoporosis or degenerative change, cortical destruction may be hard to see. Then MRI. Here we take advantage of small changes in energy state of protons when they are placed into magnetic field. We get 2D images and 3D images. Really the best study for neural elements, the soft tissues, the neurologic compromise, soft tissue involvement, and early bone marrow deposits because of we are replacing the normal fat-containing marrow. So for example, Noncontrast Ta, which is kind of the bread and butter sequence, we would see these dark areas, what we call black balls of death, dark, often that's how mets manifest them. There's also other sequences like a fat-saturated stir sequence, very good for showing both lytic and plastic lesions. So here's an example. On the left we see a CT, shows both lytic and sclerotic lesions at several vertebral bodies. And the next image is the T1 weighted image, and you can see how it nicely shows those T1 dark lesions involving several vertebral bodies. Then we have contrast enhancement, many of them enhanced. But you can see even on the non-contrast T1, we see the lesions quite well. And the last one is a stir fat saturated sequence, which kind of makes it more conspicuous. CT myelogram is an invasive study. We need to get contrast into the intrathecal CSF space. And so it's similar to CT, but it's very good for showing you the relationship between the CSFs containing spaces, because that's where the contrast is, and bony structures. Also an alternative to MRI if patient can't have one. Just a few words about the bone mets in general. They involve all the compartments. Spine is actually the third most common site after lung and liver, and most common osseous site. And when the mets are in the spine, they're usually the extradural space. I'll briefly touch all the spaces. So mets usually in the extradural space. 60 to 70% of patients with systemic cancer will have spinal mets, and it varies by tumor type. The tumors that really like to go to bone and the spine are breast and prostate. You can see the percentages there. And both of these are more typically sclerotic and blastic versus lytic, and prostate certainly even more so. Very briefly on treatment response, it's certainly a topic of many individual talks, but one thing is the standard imaging modalities are somewhat non-specific and limited. MRI is commonly used. One thing about MRI is that the enhancement may not change. Certainly increased enhancement, increased tumor volume, but if it doesn't decrease, it doesn't mean tumor is not responding. Enhancement may not change. Some advanced MRI modalities that can be used are diffusion, DWI, that we use in the brain, for example, to see stroke, can also be used here because it also finds tumor cellularity. So if there is treatment response, the cellularity decreases. So DWI, or diffusion imaging, ADC being the the quantitative value that we follow will increase, meaning that tumor is less cellular. So that can be used. DCE MRI is the perfusion study, so we can do MRI perfusion, and so if there's a decreased perfusion, that's a sign of successful treatment. Bone scan, really, as we discussed, measures biologic activity, doesn't evaluate for structural integrity. So if you're doing that way, you want to combine with CT or plain films to evaluate for bony structures. Also be aware of something called scintigraphic flare, where you may have this osteoblastic healing response. And so things may look worse, but they're actually better. And then PET, of course, can be used as well. And we talked about the PET already. One thing I want to introduce to you is the American College of Radiology ACR appropriateness criteria. You can look it up. Here's the link. It's something that ACR has put together for a whole variety of imaging indications, not just spine, but basically across the spectrum. And it kind of ranks the studies to order in relative how appropriate they may be for that particular condition and when to use. So it's a very valuable resource. Definitely recommend you take a look at it. I'll just give you some examples as they pertain to our topic today. And they present the information in these type of tables, so where there's the condition and then kind of the qualifiers, what specific scenario we're talking about. On the left column, they list the radiologic procedures. They give them a rating, and it's a rating scale from 1 to 9, where 9 means usually appropriate, and 1 means usually not appropriate, and everything in between. Then there's some comments, and then the radiation level, because one thing we have to remember, a lot of our studies have this side effect of radiation that you have to keep in mind. So, for example, in this case, we have a low back pain clinical condition, basically no red flags, and in the next slide I show you some of the red flags. And what ACR is saying is that basically all the modalities are 2 or 1, meaning usually not appropriate. So basic low back pain, no red flags, no imaging needed. These are opinions, of course, but this is what the ACR are saying. And here's some of the red flags. You are all aware of these, so we don't have to go over this, but when you have one of these, now you have low back pain, you have one of these, now you will see that, okay, now imaging is indicated. And the study of choice that has the highest rating is the MRI, without and with contrast at 8, so 9 being the highest, so usually appropriate. And then other studies similarly following, CT slightly less desirable, but MRI being preferred, but CT, of course, if a patient can't have one. Okay, now here's a patient with breast cancer. Initial presentation has back pain and hip pain. The study of choice here that the ACR is recommending you start with is a bone scan. Nuclear medicine bone scan has a rating of 9. Basically, this is the screening study to be done first, so you can see if there are lesions that are suspicious. As you remember, I said that only 50% of the lesions that light up may be mets, but this is basically you're just kind of surveying, am I dealing with metastatic disease? And then you do radiographs afterwards to characterize what you found on the bone scan, and you can consider PET as well if the bone scan is negative and if the PET will influence treatment. Here we have a metastatic bone disease. The patient has a known malignancy, back pain, partially collapsed vertebra, that was seen on X-ray. Study of choice would be MRI, basically to differentiate osteoporotic collapse from destructive lesion. So MRI will give you that answer. That would be the study of choice. You can also consider bone scan here. They give it a rating of 8 to find additional lesions. And PET, kind of same indication as on the prior condition. Now here a patient with metastatic bone disease, but it's a multiple myeloma patient. Study of choice here would be just the X-ray has a highest rating. MRI for neurologic symptoms. That would be the indication in multiple myeloma patient to do MRI to find if there are neurologic symptoms, find the cause for those, and to differentiate again for benign versus malignant fractures. primary bone tumor. So if you're screening for a primary bone tumor, the basic X-ray is the most recommended study to start with, because a lot of bone lesions have very, very characteristic appearances on bone X-ray. We have done this for decades. So sometimes just a simple X-ray may be diagnostic, so you want to start with that. Okay, now here is a variant of that. You have positive symptoms, but radiographs were negative or findings did not explain symptoms. Now you do MRI. MRI would be your study of choice in this case. You can do bone scan to see if you can try to localize that way, but it's, as you can see, has only rating of 5, so it's kind of in that intermediate category. MRI would be your study of choice here. So primary bone tumor, you found something on radiograph, but you couldn't tell if it was a malignant lesion with a mineralized matrix. So now MRI would be the next study. It can hopefully give us that answer. And we see lesion on radiograph. It looks aggressive. It's suspicious for malignancy. Again, very similarly, MRI would be your study of choice. To look for those additional things, neurologic compromise, pathologic versus non-pathologic fractures, things like that. So when we talk about spine tumors, very important thing is this location, which compartment it is in. So this is a kind of idealized schematic view, but there's these 3 areas that we need to consider. On the very leftmost image, we have extradural. The red is the tumor. Extradural tumors. Then we have intradural, extramedullary, and then intramedullary. So these look different. If you look carefully, we will notice we'll often be able to place the tumor on MR or CT if you look at this. So for extradural tumors, they'll compress the cord, they compress the CSF space, but since they are in the extradural space, this is the leftmost image, we expand that space, so we often see this fat capping above and below the tumor. And similarly for intradural extramedullary in the middle picture, since we are now in that CSF space, we expand that CSF space above and below. So that helps us identify the tumor in that space. And the differential diagnosis, and I'll give you some brief tour of those, are different in all of these different compartments. So that's why it's very important to place it into these compartments. And then intramedullary tumors, we expect to see cord expansion. So intramedullary tumors, there's a long list. The common ones are the ependymoma, astrocytoma are the most common, and both have variants, and there's a whole slew of other ones that are less common. In that intradural extramedullary space, the most common ones are meningioma, schwannoma, and then neurofibroma. And then other ones, including metastases and drop metastases if you have a primary CNS malignancy in the brain. But most tumors in this location are benign. Extradural, so in the extradural space, so now we're outside the CSF space, outside the dura, we have a whole set of conditions that are not tumors, but this is where metastases often go. We got leukemia, lymphoma, meningiomas can be in this space. Primary bone tumors are in this space as well, usually. And then the intramedullary neoplasms, just a few more words on that. These are rare. They are 4 to 10% of CNS tumors. And we expect to see enhancement, cord expansion, and sometimes we get syrinx and cystic changes as well in the cord with these lesions. Ependymoma, as I said, is most common in adults, astrocytoma most common in children. These two together are 70% of all the intramedullary tumors. If there is no cord expansion, you should think something non-neoplastic, because if you have an intramedullary tumor, it should really expand the cord. So you have all these other conditions that can happen within the cord. I would suggest you think of these conditions, not tumor, if you don't have cord expansion. That is really the single biggest thing for intramedullary. And since ependymoma, astrocytoma are the most common, here's a table that shows you some of the differences to help us identify or suggest which one we favor. There was the age, as I discussed, but also where are they in the cord. Ependymoma is more central, tends to be more well circumscribed, has more commonly hemorrhage, and more focal kind of intense enhancement. And it also involves the conus more commonly. Other intramedullary are less rare, hemangioblastoma being the third most common. So here we have a case of an ependymoma. So on the left we have T2 weighted image and then a post-contrast image. You can see it has this, its central expansile lesion in the cord, has an associated syrinx, and the enhancement is only the small area, but it is this enhancing is very intense, it's very homogeneous. But it doesn't mean that it's throughout. So, but where present, it should be kind of homogeneous, well defined. While astrocytoma on this image, you can see it's a lot more kind of ill-defined, infiltrative pattern. Has enhancement on the second image is the enhancement. You can see very minimal focal enhancement considering the extent of the tumor, and it's more ill-defined. But both cases show that cord expansion. That's really the key feature. Ganglioglioma is another tumor I just included here. It's very similar to astrocytoma. However, the key features here are it often involves the brainstem and multiple vertebral body segments, more than 3, 4 typically. Hemangioblastoma is an avidly enhancing intramedullary lesion. On the right we have angiogram showing it's a very vascular lesion. So this is a lesion that's very vascular, so we can look for, sometimes we can see that vascularity on MR, but we can certainly see it on an angiogram. There's a feeding artery and draining veins. And one thing about the intramedullary mets, which of course they're very rare, but when they do happen, one thing that suggests that that's what might be present is the extent of edema is often quite a bit out of proportion to the size of the lesion. So if you have that case, think of intramedullary met. They create a lot of edema for their size. Intradural extramedullary, we talked about the two lesions here, as I discussed, where schwannoma and meningioma are the two primary players. And to help separate those two with schwannomas, the enhancements tends to be more variable, more heterogeneous. It's not dural based, but it's certainly above the dura. And it is less commonly posterior. It enlarges the foramina and tends to be in the lumbar location. It's often very high signal on T2. So here's a typical schwannoma in the neural foramen. It's expanding the neural foramen. I kind of call this dumbbell-shaped lesion. This would be basically almost diagnostic for schwannoma because it's involving here extradural and intradural compartments. This dumbbell shape has cystic components, avid enhancement, foraminal enlargement. Very typical schwannoma. Here, meningioma then, we have a dural-based lesion enhancing with dural tail. And the way you can see how the CSF is above and below the lesion suggests you the intradural extramedullary location for this tumor. Now for extradural lesions, there's some questions that can help us answer what it might be. First of all, are there multiple lesions? If there are multiple, we think of things like metamyeloma, lymphoma. Does it involve adjacent vertebral levels? If it does, we think of malignancies such as primary bone tumors like osteosarcoma, chondrosarcoma, but also things like myeloma, plasmacytoma, lymphoma. And then location in the vertebra, is it anterior or posterior elements? If it's anterior, malignant conditions we think of are metamyeloma, but there are some benign conditions that also like the anterior space. Hemangioma, giant cell tumor, for example. Posterior elements, we think of benign entities such as osteoblastoma, osteochondroma, or aneurysmal bone cyst, but also malignant lesions can extend to the posterior space. Chondrosarcoma, osteosarcoma can involve both anterior and posterior. So just a brief tour of some of the bone lesions, now extradural lesions. This is a benign entity, bone island. In osteos, we see this a lot. What you know, this is lesion is not expansile, and while it's not entirely irregular, we could take a pen and draw a boundary around it, and it hasn't destroyed the cortex. So these are all benign features. So we think of benign entities, in this case, bone island. Osteoid osteoma is very characteristic on a CT. Here involves the posterior elements. We see this lucent rim and central sclerotic nidus. This is a diagnostic for this benign entity called osteoid osteoma. No, no really differential diagnosis needed. Osteosarcoma, malignant entity, you can see characteristic features of malignant entity. Very expansile, cortical, breakthrough, heterogeneous lesion, involves adjacent soft tissues, enhances, and I included a pathologic slide here. You can see how highly cellular it is. So very heterogeneous, cortical breakthrough, expansile, malignant osteosarcoma. Chondrosarcoma is similar. The difference here is that the bony matrix that we will see very nicely on CT looks different, where on osteosarcoma tends to be more like fluffy, kind of cloud-like. Here we see these rings and speckles and arcs. So that's, we think, more chondroid type of lesion, chondrosarcoma, because of the malignant features that we see. We see cortical breakthrough, we see expansile lesion, we see multiple compartments involved. Plasmacytoma, just a diffusely lytic lesion on a CT, but on MR we see there's an extensive epidural component here that is associated with this tumor. Hemangiomas, we see this a lot, very typical MR appearance, both on MR and CT. On MR, we see often a T1 and T2 hyperintense lesion. Is not expansile, hasn't broken through the cortex, doesn't involve adjacent soft tissues. Really diagnostic of hemangioma. On a CT, we see this very typical corduroy appearance, and then we look at it end on, we see the specks, diagnostic of hemangioma. Aneurysmal bone cyst arises from the bone. It's a lesion that tends to bleed a lot, so we often see blood levels in these tumors of different ages that we can, on MR, see the different ages of blood. And see, even on CT, we can see fluid levels. So looks like a tumor that has bled, expansile. So just to summarize on malignant features that we look for, poorly defined margins, something we definitely look on every case. Is the bone destruction kind of permeative type? Has there been cortical breakthrough? Associated perivertebral soft tissue mass? And does it involve posterior elements? These are all very key questions we have to answer. And if we have these findings, we definitely think of malignancies, some of which I highlight, but there's there's a long list of possible malignancies. Involvement, or when the discs are high, brighter than the bone diffusely on the T1 weighted image. So bone marrow is kind of diffusely hypointense. We think of diffuse marrow infiltration. There's both benign and malignant causes for that, but certainly have to keep in mind the possibility of malignant involvement creating that appearance. If you have intramedullary, so in the cord, mets, that means aggressive cancer, because it's very rare for mets to go there. So when they do, I would say think of aggressive cancer. So just to conclude here, then, location is very important. I told you about the three compartments, the extradural, intradural, extramedullary, and intramedullary. So we try to place the tumor in these compartments because that definitely helps us with the differential consideration. We often consider imaging the entire neuroaxis, so if you see something in the brain, we image the spine, vice versa. I walked you through some of the imaging workup for different conditions and introduced you to this concept of ACR, appropriateness criteria, which I definitely recommend you take a look. Gives you idea what studies to order for different conditions. We went over some of the representative lesions and talked about the malignant characteristics of tumors.